Hi everyone, welcome back to my YouTube channel, and today we're going to discuss about Parkinson's disease. Parkinson's disease is a chronic neurodegenerative disease. Its cardinal features are rigidity, bradykinesia, and resting tremor. The cause of Parkinsonism. Here is the term true Parkinsonism. There is another term also which is known as pseudo-Parkinsonism, which mimics the symptoms of Parkinson's disease. The causes of true Parkinsonism are: in Parkinson's disease, the movement difficulties, they are collectively known as Parkinsonism. It is occurs due to the degeneration of dopamine secreting neurons of substantia nigra. Its cause can be anoxia, lack of oxygen, maybe due to cardiac arrest. It can be familial or it can be drug induced like metoclopramide, clopramazine, or it can occur after encephalitis also. There is very important term to know, that is MPTP, which means 1-methyl-4-phenyl-1,2,3,6 tetrahydropyridine. Because of its toxicity, it can result in Parkinson's disease, mostly in case of drug abusers. And Parkinson's disease can also occur due to the mutation of alpha-synuclein gene. The hallmark of Parkinson's disease is there will be degeneration of pigmented dopaminergic neurons in substantia nigra in pars compacta, and as it is a neurodegenerative disease, there will be reactive changes like astrogliosis, microglial cell activation, and the hallmark of this disease is presence of Lewy bodies. These Lewy bodies are spherical intracytoplasmic proteinaceous eosinophilic inclusions. They are composed of radially arranged synuclein. The clinical features of Parkinson's disease are resting tremors. Specifically, we call it pill rolling tremors. There can be bradykinesia or akinesia. There will be slowness in movement, rigidity, postural instability. There will be difficulty to start movement also and to stop movement also. The face will be expressionless, masked like face. Patient walks quickly in short steps by bending forward, which is known as shuffling gait. There will be abnormal minute handwriting, that is micrographia, and dementia is a late feature. The investigations are: the gold standard investigation is neurological examination. Radiological investigations such as CT and MRI will be normal. And single photon emission computed tomography and positron emission tomography will be abnormal, but this is not specific. For the treatment, you have to understand this figure. So the L-DOPA is the metabolic precursor of dopamine, and peripherally it can be converted to dopamine by DOPA decarboxylase enzyme, and it can be converted into 3-O-methyl-DOPA by catechol-O-methyltransferase enzyme. It can cross blood-brain barrier, and then dopamine will be formed by L-DOPA by DOPA decarboxylase enzyme. This dopamine can be converted to 3-methoxytyramine by this catechol-O-methyltransferase enzyme here, or it can be converted to DOPAC by monoamine oxidase type B enzyme. Then this dopamine, which is produced here, will be going to postsynaptic terminal in striatum, and there will be dopamine receptors and dopamine will be used. In case of Parkinsonism, our main goal is to increase the level of dopamine. So we will be increasing the availability of dopamine and we will minimize its degradation. So peripherally we will give DOPA decarboxylase inhibitor so that this L-DOPA level will be increased. Likewise, we will give COMT inhibitors peripherally and centrally. And we can give MAO-B inhibitors so that it is not converted to DOPAC. We can give dopamine agonist, and we can also give amantadine, which will increase the availability of dopamine. So let's discuss these drugs one by one. First one is dopamine agonist. These are the drugs which act on dopamine receptors. They are pramipexole, ropinirole, and bromocriptine. Pramipexole and ropinirole are non-ergot derivatives. They are more preferred one, but this bromocriptine is ergot derivative and it is not used because of its toxic effect. Next is the drugs which increase the dopamine availability, that is amantadine, which increases the release of dopamine and decreases its uptake. Anticholinergic drugs are also used. They are trihexyphenidyl and benchtropine. It helps to relieve tremors. Like that, we can also give beta blockers. That is propranolol. It also helps to relieve the tremors. Next drug is the drug which prevent dopamine breakdown. First one is monoamine oxidase type B inhibitors. They are selegiline and rasagiline. They block the conversion of dopamine to DOPAC centrally. And next is COMT inhibitors. COMT inhibitor drugs can act only peripherally or can act centrally or peripherally. Tolcapone is a drug which acts peripherally also and centrally also. It blocks the conversion of dopamine into 3-methoxytyramine. And another drug is the increased L-DOPA availability. So COMT inhibitors which act peripherally also, they are entacapone and tolcapone. They block the degradation of L-DOPA into 3-O-methyl-DOPA which acts peripherally. Next is DOPA decarboxylase inhibitor which is carbidopa. It blocks the peripheral conversion of L-DOPA to dopamine. Normally we give carbidopa and levodopa as a combination. As levodopa is a metabolic precursor of dopamine, this combination increases the dopamine level in brain. L-DOPA crosses blood-brain barrier and is converted to dopamine by DOPA decarboxylase in CNS. This carbidopa cannot cross blood-brain barrier and limit its conversion of L-DOPA into dopamine peripherally. The combination of these drugs are it reduces the adverse effect, it increases the plasma level of levodopa and prolongs the action half-life of levodopa. It reduces the daily requirement of levodopa by 75%. There are surgical treatment also. There are deep brain stimulation, pallidotomy, which is partial ablation of globus pallidus, which helps to improve the tremors and dyskinesia. Another is thalamotomy, which is the partial ablation of thalamus. So this is all for Parkinson's disease. I hope you guys understood and we will meet up in our next video.